All right, everybody, welcome to week 7. Today we're going to be covering neuropathic pain and neurogenic inflammation, not to be confused with neurogenic neuroinflammation, which I'll talk about at the end of this lecture. So, some of our objectives: what is neuropathic pain? What is the pathophysiology behind it? What are the causes? What are some of the pathways? And then how can we fix it clinically in the office? So, neuropathic pain, it's pain initiated or caused by a primary lesion or dysfunction in the somatosensory nervous system. It's usually chronic, it's difficult to treat, and it's often resistant to standard analgesic management. Again, over on the right hand side, neuropathic pain can be broken down into peripheral neuropathic pain and central neuropathic pain. So, as we know, neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. And then peripheral neuropathic pain on the left is pain caused by a lesion or disease of the peripheral somatosensory nervous system. And then central is pain caused by a lesion or disease of the central somatosensory nervous system, which I'm sure you all already knew. So just to do a little bit of differentiation between neuropathic pain and nociceptive pain, some of the clinical characteristics: the etiology of neuropathic pain is nerve injury or central sensitization. Basically, when I think of central sensitization, I always think of neuroplasticity in a negative fashion, right? Pain pathways have become so efficient that you have what's called chronic pain and central sensitization, where things that shouldn't really bother you seem to really bother you. Nociceptive pain is tissue or potential tissue damage. Some of the descriptors: people may describe neuropathic pain as lancinating, shooting, electric-like, stabbing. I'm sure you've all had a diabetic patient in your office that has shooting, numbness, tingling, stabbing, pain in the feet bilaterally. Nociceptive pain is usually throbbing, aching, pressure-like, so like a headache. Sensory deficits: they're frequent numbness, tingling, pricking in neuropathic pain, and then in nociceptive it's infrequent, and if it's present, in non-dermatomal or non-nerve distribution. So obviously it makes sense, right? If we have neuropathic pain, it should be somewhat related to following some sort of nerve route. Motor deficits in neuropathic pain: you'll see neurologic weakness. It may be present if the motor nerve is affected, and they may have pain-induced weakness. So basically, they're not going to be moving because there's pain in the extremity or other body part. Hypersensitivity for neuropathic pain: the pain's frequently evoked with non-painful allodynia or painful exaggerated response stimuli. So that's getting into that sensitization. And then nociceptive pain: uncommon except for the hypersensitivity in the immediate area of an acute injury. So basically, like if you stub your toe and then someone touches it or stomps on it, then it hurts again. But that pathway hasn't become efficient. It should heal in a little bit. That's nociceptive. So distal radiation is common. So you could have some radiation of that pain for neuropathic, and then distal radiation is less common. Proximal radiation is more frequent, so kind of in that surrounding receptive field area for nociceptive pain. Paroxysms, exacerbations, are common and unpredictable in neuropathic pain, and they're less common in nociceptive and associated with activity. So some shoulder pain, and then you move your shoulder and it hurts. Autonomic signs: color changes, temperature changes, swelling, some sweating, activity may occur in 30-50% of patients. And then nociceptive pain, autonomic signs are uncommon when it is chronic. So I know we've gone over a lot of this, but just as a reminder, remember the brain's language is repetition, so the more we do these things, the better and more efficient you'll get at it. But hypoesthesia is reduced perception of non-painful stimuli, and these are negative symptoms of neuropathic pain. Okay, so if these people have these symptoms, it's probably not neuropathic pain. Hypoalgesia, reduced perception of painful stimuli. Thermohypoesthesia, so reduced perception of heat. And then some positive symptoms: they can have spontaneous pain, paresthesias, so non-painful tingling sensations, paroxysmal pain, so shooting pain that occurs intermittently for seconds at a time. I'm sure you've all had a low back patient. Superficial pain that can be continuous burning sensation. Stimulus-induced pain. Allodynia, so pain induced by typically non-painful moving stimuli on the skin. Hyperalgesia, so a painful stimuli that's induced by typically non-painful static stimuli on the skin. And then summation, so increasing amount of pain due to typically non-painful or repetitive stimuli. So aggravating that area enough to where it becomes painful. Neuropathic pain. I found quite a few good articles for this lecture, and if you kind of look at the syllabus, we get really deep into pain. So I had to pull away from the book. I wouldn't even really rely on your book at this point, but because again, this is a master's program, I think it's really important that we go to the literature and find some decent articles about it. But the title of this paper is Neuropathic Pain, and I'm just going to read you not the whole abstract, but I won't read it to you at all. I'll let you guys read it. But basically, it just talks about neuropathic pain is, the cause, lesions, somatosensory in the system, and we talked about all that stuff. So I will not bore you too much tonight. But some of the pathogenesis of neuropathic pain, peripheral mechanisms. So after a peripheral nerve lesion, neurons become more sensitive and they develop abnormal excitability and elevated sensitivity to stimulation. Remember, this is known as peripheral sensitization. Cool little image there, so I'll let you guys look at it, but the injured area becomes increasingly sensitive to the sensory stimulation, so even a light touch may become amplified to feel extremely painful. And then injury causing pain, damaged muscle or joint, cut or bruised skin, and then it goes up into the pain signal pathways, eventually can become centrally sensitized. So pathogenesis of neuropathic pain, in talking about central mechanisms. As a consequence of those ongoing spontaneous activity arising in the periphery, neurons develop an increased background activity in large receptive fields. So remember, you have specific size receptive fields that should be around the body, and those become enlarged. So basically, your body's kind of in a heightened awareness and alert state. And increased responses to afferent impulses, including normal tactile stimuli. That is central sensitization. And again, just another cool little image. I'm a visual learner, so I hope you guys like these. But it shows on the top normal pain processing and then pain processing in fibromyalgia. So you've got the minimal stimuli on the right bottom corner there, and you get induction of central sensitization leading to abnormal pain processing because of increased release of pain neurotransmitters glutamate and substance P. So those pathways become efficient, and there's a pain amplification in the central systems or the central nervous system, and perceived pain happens even with minimal stimuli. And normal pain processing, as I know all you know, but painful stimuli, you get nociceptive afferent fibers, and then you get that ascending input into the brain perceives that, and then you've got descending modulation through the cortical paraqueductal gray areas into the spinal cord and shuts it down. So good normal pain processing is good. Bad is bad. And a lot of these images, or that previous one wasn't, but a lot of these images moving forward are from some of the research articles. So again, if anyone wants the research articles, let me know. I really enjoyed some of these. So some of the peripheral neuropathic pain things that we'll see is trigeminal neuralgia, so within the face or intraoral trigeminal nerve territory. So it could be one-sided, it could be both. Posterior neuralgia, so it could be a unilateral distribution in one or more spinal dermatome, which if anyone's ever had that, I've heard it's very, very painful. It can be very dangerous if it gets up to the eyes, and if there is any suspicion of posterior neuralgia going into the orbital area, they need to be referred out immediately to preserve functioning of the eye. Peripheral nerve injury pain, so in the innervation territory, again, we're all healthcare providers here. I'm sure we've all seen our fair share of peripheral nerve injury pain patients. Post-amputation pain, I have a really cool video at the end of this slide to talk about this, but in the missing body part or the residual limb, we have to remember that even though that body part is missing, the somatosensory and motor areas of the cortex on the contralateral side still exist. So you could have perceived pain even though there's something not there. And there's really cool rehab coming out to help fix that. And there already is some really cool rehab out to fix it now. Painful polyneuropathy, so you'll see typically polyneuropathy in heavily associated metabolic conditions such as diabetic neuropathy, patients who've gone through chemo for cancer. So it's in the feet, it's often in the lower legs, thighs, and also the hands. And then painful radiculopathy, which I again sure all of you know, and all of you can recite the brachial plexus and all of its innervations and nerves and functions. But yeah, good thing to keep an eye out for that and determining is it a radiculopathy due to some sort of musculoskeletal issue down the kinetic chain, or is there a disc issue? So just keep an eye out for that. Moving on to central issues related to neuropathic pain. So neuropathic pain that's associated with spinal cord injury. So at or below the level of a spinal cord lesion. And of course, you'll see other things associated with the spinal cord. So changes in touch temperature, changes in vibration, stuff like that. Central post-stroke pain. So they'll have contralateral to the stroke. In lateral medullary infarction, the distribution can also involve the ipsilateral side of the face. So you don't really have to know that, but once you really know the anatomy and you know where things are, you'll be able to determine clinically what's going on, which again, I'm sure y'all are really good at. Central neuropathic pain associated with MS. So I actually have read, I couldn't find it for this lecture, but I'll try to provide it. Well, first of all, it's combined distributions of those observed in spinal cord injury and stroke. But with MS, obviously, you're going to kind of see all over demyelinating conditions. But I read an article, and I believe this is from one of my mentors, Datis Karazi. And if you're ever interested in learning more about functional neurology and functional medicine, that guy has some amazing information from the clinical side and then also from the research side. He's done some amazing things for our profession as chiropractic, but also in pursuing some really good functional neurology endeavors. But one of the literature articles he showed me was for patients that are suffering from MS, you actually can't see brain changes, demyelinating changes, until about 40% of the nerve is changed. So that's pretty scary. Like if you can learn to detect MS and you can see signs and symptoms clinically, some of those subliminal signs and symptoms, you can really do the patient a huge favor by saving the myelin and saving all the nerves and the brain as well before it gets to a point where the rehab can become very difficult. So just know for the tests differences in peripheral versus central, know which conditions would be more peripheral, which would be more central, and what they may look like. We won't get super duper specific. But again, some of the common causes, so lesions or diseases of the somatosensory nervous system can lead to altered and disordered transmission of sensory signals into the spinal cord and the brain. Common conditions associated with neuropathic pain include postherpetic neuralgia, trigeminal neuralgia, painful radiculopathy, diabetic neuropathy, HIV infection, leprosy, which you'll see in like Brazil, West Africa. That's not very common here, but it was on the list. Amputation, which we'll show a little thing later, peripheral nerve injury pain, and then stroke. If you remember the stroke patient that I presented last week, funny enough, I got to see him today, and his motor function is coming back pretty great. I'm really excited for him, and his pain threshold is much better, so he can appreciate more pain. His peripheral and central sensitization has dampened, so good stuff there. Another good image from one of the papers. So an overview summary of peripheral and sensory mechanisms that lead to neuropathic pain. So remember, things happen in the periphery. If it's persistent in the periphery, you'll get central changes, and the central changes can create neuropathic pain. So altered ion channel expression triggering enhanced membrane resonance, rhythmogenesis, and ectopic spiking with increased cellular excitability. That's getting into the neurophys that we haven't super duper dove into. Central mechanisms sprouting myelinated nerve fibers into the lamina 2 of the spinal cord, increased glutamate release, which if no one's really familiar with glutamate is so excitatory for the nervous system. And we'll talk a little bit about why glutamate well, it serves its purpose, we'll say that, but also if it gets out of hand, it can be really bad for the nervous system. Evoking fast excitatory synaptic potentials, expression of BDNF and substance P. You get neuroplastic changes in central pain, descending regulatory systems, and you get the glial cell activation, and you get microglial cell priming. You can get a chronic and pro-inflammatory response. And then whenever you have inflammation, I always tell people it's really difficult to drive positive plasticity. So you've got to look at ways to dampen the inflammatory pathways, whether it's through different types of adaptogenic herbs, supplementation, or doing some, just physical exercise or meditation or anything like that to just put some of the fuel to the fire away. So classification of pain, you've got neuropathic pain versus musculoskeletal pain. All of you guys know that very well. Guys and gals know that very well. This was one of my favorite images, and I was able to find it on a couple of different conditions, but it's from Nature's. So again, I believe it's from Nature's. It was one of the research articles, and what a cool little description here of neuropathic pain. So I won't read all through it, but they're just, you could literally just walk right through here and see what we need to be doing, how you can test for it, what's the epidemiology. It doesn't go into too much of like the chiropractic care or the functional medicine or nutrition side if people are into that. But a good little thing to have to read over, and I will pull some questions from this diagram on the test. I'm not going to read through it, but I really like it. It's a great little thing to have. And then these are some of the pathways. So we know we've got the ascending pain pathways that'll fire up spinal cord into the cortex, which you guys don't need to know the super duper specifics of it, but we should have good descending pain pathways to descending pain modulation pathways to help pain suppression. Those are very important if they don't work good. So if you don't have a good brain, you can't modulate the pain. So it's important that we have good brain function. And just for the test, I'll ask a couple of questions. It won't be anything super duper difficult, but you've got to know, your fiber sizes again. Some of the pathways, and the pathways are shown here. So you've got a limbic pathway, which of course is super duper important because you have to create some sort of emotional association with pain, right? You don't want to continue walking up to the stove and forget that the stove is hot. You got to remember, oh man, I hate that stove. That's the worst stove in the world. I'm never going to go next to that stove again. And then some of the other pathways as well. Cool little pathway on the right is the noradrenaline pathway. So you'll get that response in a demodulation or a descending fashion. So just this is the excerpt from it from the paper. If you want to read exactly what they're talking about, so I can pull a couple questions from here on the test, but just take a look at it. I really think if you get to know pathways good, it just makes everything so much easier in your head when you're looking at things. You don't have to know them perfectly, but if you can say, hey, if this is a small fibers are pain fibers. If this is a large fibers have more representation in the cortex. I could use large fibers to shut down small fiber pathways, create more plasticity in those pathways, make a better brain, and then get rid of chronic pain. So highly recommend just reading that, checking it out, and I'll pull some questions from there as well. So back to this paper, chronic neuropathic pain is actually more frequent in women than men. Men always seem to get off easier. Just kidding, guys. Sorry, but we do. And in patients 50 years age, it most commonly affects the lower back and lower limbs, neck, and upper limbs. So neuropathic pain is walking in our offices every day, I'm sure. Lumbar and cervical painful radiculopathies are probably the most frequent cause of chronic neuropathic pain. And consistent with these data, a survey of greater than 12,000 patients with chronic pain with both nociceptive and neuropathic pain types referred to pain specialists in Germany. I don't know why they didn't come to the States. No, I'm just kidding. Revealed that 40% of all patients experience at least some characteristic of neuropathic pain, which is the burning, numbness, tingling, with chronic low back pain or radiculopathy being particularly affected. So we see it all the time in the office. Okay, I know you're going to have to zoom in for this. I tried to make this image as big as possible, but these are some of the medications that are being used for neuropathic pain. So you've got some tricyclic antidepressants and the mechanism of action, which I think we need to know this, guys. I think it's really important that, especially at a master's level, we know what medications patients are on, what the mechanism of action is, why they're using it, and then what are some of the contraindications, and what do we need to look out for. So I always tell people, when you're doing a neurological exam, if you don't know what medications they're on, then you may just be treating side effects of medications, right? So for example, if we see a kid that has ADD, ADHD, and in our office we have video nystagmography where we'll test eye movements, but they're on some sort of methamphetamine, their eye movements are going to be completely different than if they were off it. So it's really important to know medications. And just do a little bit of research. I think it's a great thing to know. So that's why I provided this chart here. So I am going to ask some questions on the test about medication. I will ask some questions about the mechanism of actions, and then I'll just ask what are some of the adverse effects and just some of the simple stuff that you should know. But here we got tricyclic antidepressants, serotonin, so SNRIs, calcium channel ligands, so gabapentin. I'm sure like all patients that I've seen with neuropathic pain are on gabapentin. Topical lidocaine, which if you guys have ever used BioFreeze, that's not lidocaine, but it's kind of similar. And then capsaicin, that's really high in the literature. That seems to help a lot of people with the inflammatory pathway. And opioids, which, that's an epidemic. People should not be on opioids. If you have patients coming in on neuropathic pain for opioids, it's a little bit old-fashioned in my opinion, and they probably need to seek other measures. Okay, so just going into some of the treatments besides pharmacotherapeutics. So we've got physical therapies. I don't know why they said physical therapies, but physical therapy, so exercise and movement representation techniques, they've been suggested to be beneficial in neuropathic pain management. So for example, mirror therapy and motor imagery are effective in the treatment of pain and disability associated with complex regional pain syndrome 1 and 2. Mirror therapy is an awesome therapy, and it's super duper cheap and easy to use. All you have to do is have one of those $10 wall mirrors from Walmart, and you can do stroke rehab therapy with it. You can do pain modulation rehab therapy with it. So we have one in our office, and then most of my patients who we use it with, they always go and buy one at Walmart. So obviously you'll have patients going to see physical therapists. Low-level laser, we just got a really great laser in our clinic. Actually, it was donated by a new laser company called Avent Lasers, Avent Wellness. But I'd never used a low-level laser before, and I'm always kind of hesitant to bring new things. But those things are awesome. I'm sure everyone here has used one in the past, but I really like using those adjunct to other things. So just a great way to help, another route to the receptor to provide receptor-based therapy. And again, I'm just showing you these because these are in the research that show that these types of therapies seem to help patients with neuropathic pain. So if you're ever doing something in the clinic and people are like, well, why are you doing that? Well, it's evidence-based practice. That's why. Electrical stimulation or exercise. So this is an article that found both electrical stimulation and exercise are promising experimental treatments for peripheral nerve injury that seem ready to be translated to clinical use. So, we'll use TENS units in our office. We use something called a rebuilder. We have an SSAP that you use to diagnose nerve function, but we'll also use it to activate nerves to create plasticity, which I think I spoke about in the last lecture. But one of the papers I found, this was awesome. So just talking about driving plasticity, driving BDNF, providing receptor-based therapy to make changes to the peripheral and central nervous system. This is a cool image here. So electrical stimulation accelerates axon outgrowth across the site of nerve transection and surgical repair. So regrowing the nerves, right? You got the repair sites here, and this guy has been cut, and you've got some good, happy. This is an electrical stimulated one, and this is unstimulated, so you can see the difference, right? This one just looks, I guess we'll say, sexier, but you gotta do stuff to just drive plasticity. People need to be moving. People need to be stimulated. So cool article there. And I believe that was actually from this article right here. And that was at Emory, right down the road from me. So dietary intervention for chronic diabetic neuropathy pain, randomized controlled pilot study. The conclusions in this were that improvements were seen in some clinical and pain measures. The pilot study suggests that the potential value of a plant-based diet intervention, including weekly support classes, because like if you're not going to eat bacon, you definitely need some support for treating painful diabetic neuropathy. So basically, it makes sense, right? Eating something very healthy, putting good things into your system, probably changing your glycemic index, your fasting blood sugars, your hemoglobin A1C. Diabetic pain is probably going to shut down because you got some good blood sugar regulation and you're eating healthy things, minus the bacon. And I think this is the last one. We're going to have, I believe, a whole lecture on nutritional supplementation for neuropathic pain, but this has been one of my new favorite supplements to use in the office, and I just wanted to share what the research says about it to you guys. But I use magnesium L-threonate for all of our concussion patients, and the reason I use it is because I tell patients that magnesium serves as a plug for the cell. And when there's cellular damage, that plug sometimes gets removed, and it allows things like glutamate to get into the cell. And glutamate will create what's called cell-induced excitotoxicity. It'll drive inflammatory pathways. It'll change the function of the cell. The cell won't function as well. But if you can put the we'll say the plug back onto the cell, which is what magnesium serves as, then you can start to make some positive changes to the nervous system. So I love magnesium, and I love magnesium L-threonate because what the research shows is that magnesium L-threonate will actually cross blood-brain barrier and create positive changes to the brain. But this paper in particular says it prevents and restores memory deficits, which is cognitive, with neuropathic pain by inhibition of TNF alpha. So a cool paper. Again, just kind of, I guess for me at least, reinforcing the fact that this is an important supplementation that you can find through dietary measures, but just to have patients take and feel better is awesome. So here's a quick video. Phantom limb pain in augmented reality. I think Dr. Twaddle is coming down to visit me on Wednesday, and I don't have our VR set up yet, but we are using video games to help brains get better, and eventually the software that I use will have virtual reality in it and augmented reality. But here is a cool little video, which I hope will play. Oh, that's my wife over there. So let's see here. Okay. Hopefully you guys can hear it. Okay. So phantom motor execution alleviates phantom limb pain via competitive plasticity. So competitive plasticity and the reversal of cortical reorganization. So patients train the system to recognize various phantom movements. So you see electrodes, the intended movement, and then you got EMG patterns there, and you're looking at the screen. So the patient's pronating and supinating their hand, trying to do some matching there, and their brain seeing it, right? So the phantom limb movements were visualized with a virtual arm. So this is cool. Check this out. Electrodes used to detect the muscle activity going on in the arm there. And so now he actually sees himself on screen with an arm, right? So simultaneous movement. He's moving it, pronating, opening his hand. His brain's seeing it, so you're getting some cortical changes. Game control. So phantom limb movements were used to control computer games. So now he's using his hand, or his augmented hand, to steer a car. So such a cool application of receptor-based therapy to help. And then this is pretty neat too. So the green arm shows the target posture, and he has to try to match it. So his silver arm, yep, just like that. So it can detect the changes in muscle lengths to see if he can actually do it. Reduced by 50%, the pain was. Intrusion of PLP on activities of daily living was reduced by 50%. Lots of 50%ers, so good results. And that to me, it just shows that there's so many different therapies out there that can help people, and even if we're just aware of it, it's good because people need to know that stuff like this exists. But you can do some really good things. This patient would probably benefit really well from mirror therapy. So setting up the mirror on the deficit side so that it's blocking it. So the mirror would be facing towards his right, and he would see his right hand in the mirror, but in the mirror, it would look like his left hand. So then he would have his left hand back. His brain would at least think that, and you get activation and cortical reorganization and competitive plasticity to make changes there and shut down pain. So pretty cool application. Okay, neurogenic inflammation. We're not going to go too much in depth into this, but some of the objectives again. So what is it? What is the pathophysiology behind it? What are the causes and how can we fix it? So neurogenic inflammation is a neurally elicited local inflammatory response that's characterized by vasodilation, increased vascular permeability, mast cell degranulation, and the release of neuropeptides, including substance P, calcitonin, and gene-related peptide. So it's an inflammatory response at the peripheral areas. It appears to play an important role in the pathogenesis of numerous diseases, including migraine, psoriasis, asthma, fibromyalgia, eczema, rosacea, dystonia, and multiple chemical sensitivity. And that image there is just showing that there's injury, there's inflammatory changes, and then you get vasodilation. So some common causes. This is straight out of a research article. There are multiple pathways by which neurogenic inflammation may be initiated. It's well documented using both animal models and isolated neurons in vitro that capsaicin, heat, protons, bradykinin, and tryptase are upstream regulators of the intracellular calcium influx, which can be bad for the cells. This results in inflammatory neuropeptide release. And what I should say here is, remember, inflammation isn't bad. It's the constant chronic inflammation that's not well controlled. That's when it becomes bad. In contrast, it is thought that prostaglandins, E2 and I2, cytokines, interleukin 1-6, and tumor necrosis factor don't cause neurotransmitter release by themselves, but rather excite sensory neurons in the lower threshold for firing and cause augmented release of neuropeptides. While neurogenic inflammation has been extensively studied and well documented in peripheral tissues, until recently the concept of neurogenic inflammation within the CNS has remained largely unexplored. Given the capacity of neurogenic inflammation to influence vascular permeability and lead to the genesis of edema, it has now been widely investigated for its potential to influence the blood-brain barrier permeability and vasogenic edema within the brain and the spinal cord under varying pathological conditions. So now you're having, it's more of a central neurogenic inflammation or neuroinflammation. And then here is an article. This is from an article. Acute CNS injury leads to the initiation of both neurogenic inflammation and you get that classical inflammation. So this is neurogenic inflammation will start due to injury to the brain. So if you ever have a concussion patient, you have to remember that there's a chemical cascade that happens that's an inflammatory process. And again, the inflammatory process is a protective mechanism to a certain extent. But once those microglial cells get activated, if they become primed, they end up just going around the nervous system and in the brain and start shooting away kind of like a chicken with their head chopped off. They don't know what they're doing once it gets to a certain level. So it's really important that if you do have a patient that's had a traumatic brain injury or even a severe whiplash injury, that you ask them some specific questions to see if they're suffering from what I consider to be a silent epidemic, post-concussion syndrome, because I feel like this right here is at the root cause of post-concussion syndrome. And people aren't fixing it. Traditional medicine isn't fixing it. The rest and sleep it off therapy is definitely not fixing it. So anyways, insult to the brain, release of S&P, you get neurogenic inflammation, which can cause some vasogenic changes, increased blood-brain barrier permeability. So just, if no one knows, I'm sure y'all know, we have like a screen door to our brain, which is our blood-brain barrier. And anytime there's an inflammatory response, think of it like the tight junctions in your gut. They start to separate, so you get little holes in the screen doors, and then mosquitoes start to fly into our brain, or inflammatory cytokines that shouldn't be there, large proteins that shouldn't be there, causing increased issues in the brain. So you get vasogenic edema, you can get increased intracranial pressure, which can lead to ischemia, blood vessel compression, tissue compression, herniation, and death. That's severe, right? Because then you got brain swelling, which is pushing down on your brainstem areas, which causes death. So we usually, for me in my office, we stop right about here. Post-concussion syndrome lives right about here. And the reason that's important is because we're going to go over a really interesting concussion case in a second. And then you got your classical inflammatory pathways that everyone learned in undergrad, or that stuff. But it's important because you don't want to have overactivation of that either. Okay, so I believe that's pretty much all I have for neurogenic inflammation. We could do a whole lecture on neuroinflammation because not only do I feel that it plays a major role and may be the root cause of post-concussion syndrome, but also people with autoimmunity, people with really severe food allergies. If anyone in your office says that they have brain fog or their brain just feels different, if there's a slowness of speed, I always say that there's some sort of thunderstorm going on in their head, they can't think clearly, there's a high probability that they have neuroinflammation, their blood-brain barrier has been breached, and they have changes in the way that their immune system is functioning. So just important stuff. But anyways, back to Mag 3, which is my new favorite supplement. And You guys can order these online. I use specific companies. If you have any questions, I don't know if I'm supposed to mention the companies on here, but I have a couple that I really like to use. My wife and I use them every day. I use them for my Alzheimer's patients. I use them for the concussion patients. Just a great thing. And the reason I use them for my Alzheimer's patients is because of this article. Even though they're mice, one of the medical doctors I work with, she's always like, Ryan, you have to find articles on humans. I'm like, I don't know. They seem to always be on like rats and stuff. But anyways, if I see it and they said it works, I'm going to try it if someone's selling it, just to see if we can help people. So elevation of brain magnesium prevents synaptic loss and reverses cognitive deficits in Alzheimer's disease mouse models. So as soon as I read this, I got really excited because Alzheimer's is not great. I've seen some really, really debilitating Alzheimer's patients, and it breaks my heart for the patient and also for the patient's family. So anything we can do to help. But the results, I'll let you read. I'll just go to conclusions. It suggests that the elevation of brain magnesium, which when they say brain magnesium, it's magnesium L3 and 8, because it's a specific form of magnesium that can cross the blood-brain barrier that's not leaky. Our results suggest that elevation of brain magnesium exerts substantial synaptoprotective effects in a mouse model of Alzheimer's disease, and hence it might have a therapeutic potential for treating humans with Alzheimer's disease. So, great supplement. Okay, so I'm going to go over a case study to end this lecture on neuropathic pain and neurogenic inflammation. If anyone's ever had a concussion case and wants to talk more about it, I'd love to. This is something I've become very passionate about because, again, I've just seen so many, and I know that there's a silent epidemic, and people aren't getting the correct treatment that they need. And us as what we'll say in this class, receptor-based therapists or chiropractors or healthcare practitioners, we can do some super duper simple things to help these people at least feel better. Sometimes they may not be cured, but they can feel better. So that's me with my long hair when I had my superpowers. But post-concussion syndrome, transcortical motor aphasia, and that's where I work. I use these slides for work presentations. So I'm in Atlanta, Georgia. Anyways. So this was a 15-year-old male that presented to our clinic from Alaska, and he was unable to speak after a concussion. So his name was Jesse. Him and his dad are becoming big advocates for concussion therapy because he went everywhere in Alaska and just couldn't find any help anywhere. But he was cross-checked in an ice hockey game, and he suffered a really bad concussion. He hit the back left side of his head, and it was actually his second concussion that he had sustained, this one being worse than the first. And he knew he had a concussion as soon as he got up. He went to the locker room. He ended up, I think he threw up. He got really nauseous. So he knew he had a concussion. But his last concussion, he was able to kind of sleep off, rest, eat some good food, and feel better. This wasn't the case, though, because 3 days after the concussion, he woke up and he couldn't vocalize or verbalize. So anytime he would try to speak, he kind of hit what he'd describe as a speed bump. This is a great a great image for anyone that has aphasic patients and they're trying to figure out what's going on. I think Jesse kind of had a combination of like a transcortical motor sensory aphasia with a little Wernicke's. It was all right in here. And what that means, just from a concussion standpoint, is that there were some neuroinflammatory pathways that created synaptic changes and created a little thunderstorm on the left side of his head. And he just couldn't do things properly. It wasn't like a stroke where you see all these horrible motor problems and sensory problems, but he just couldn't produce speech, which is no fun for a 15-year-old young athlete, right? So, great little picture here for everyone. So his chief complaints, he had brain fog, he had chronic fatigue, he couldn't produce speech. Episodes of seizure-like activity, he would have absence seizures. So his dad would describe him, hanging out at a game, watching something, and then all of a sudden kind of just stare off into space. And I count that too with post-concussion syndrome, just that neuronal fatigability and the inability for the brain to really produce some endurance, and then eventually going into seizure-like activity. And he was unable to play sports, so we had to figure out what's going on for him. So his physical exam, we shoot x-rays on all of our patients. He had a pretty gnarly kyphosis. We call it text neck in the office. ankle clonus bilaterally, which is an upper motor neuron lesion sign. So we knew that there was some brain dysfunction because a good healthy brain should be able to mitigate an ankle clonus response. He had dizziness with his head tilted back. He felt horrible with his head tilted back in both canal positions of the right and left. He couldn't perform coordinated movements on his left side. And he had some difficulty on his right side as well, but he was way worse on his left than his right. He was unable to perform one-legged standing bilaterally, so I'd have him, do a Romberg's, and he was okay at it. He's a 15-year-old guy, but then when he tried to stand on one leg with his eyes open, it was very unstable, and then he couldn't even do it with his eyes closed. And then after just a little bit of stimulation, even just some of our testing, he would just get super duper fatigued. And he had an absent gag reflex. And the literature shows that within hours after traumatic brain injury or concussion, you get gut changes. You actually have changes in your microvilli. So just like damage to the blood-brain barrier, which is your screen door for your brain, you get separation of the microvilli in your gut, which can create what's called leaky gut. So you lose the screen door in your gut as well, which is important because if you have brain inflammation and gut inflammation and then you have foods, you have exaggerated and abnormal immune responses to those foods, and you're further driving some stressful pathways within the system that don't promote healing. So some neurological rehab exercises that we use in the office, we started with some really light chiropractic adjustments, and we did those. He flew in for a week because he was coming in from Alaska. We played a video game called Neurosage. So Neurosage is a really, really fun tool that's coming out in the functional neurology world that I've been lucky to get involved with, using different acoustic frequencies within the ears, using vibration platforms, and then using specific eye movements on the screen and color therapies. So vibration both on the platform, and then we'll use, it's a genie rub, so we'll use that on all of his extensors to fire extensor tone and get better brain function. We have him gargling. Gargling is one of my favorite, easiest exercises to do to fire into the vagal motor nuclei. So activation of the posterior muscles in your throat will fire into your pontomedullary system and fire up the parasympathetic pathways. And we know that, broken down nervous system is usually driving fight or flight or sympathetic responses. So anything we can do to kind of bring the seesaw back the other way. Mirror writing, which I'll show you a video of in a second, and then vestibular rehab. So a lot of research shows that in a concussion or traumatic brain injury, vestibular rehab gait stability exercises are very necessary, and sometimes it takes way more than 1 or 2 times to get people fixed. So I'll show you a quick video. So on the left, he's really good at this game. This is actually one of the harder games. But he's standing on a vibe plate, listening to acoustic frequencies, doing nonlinear complex movements to activate his cerebellum on the left side, and then watching the screen, doing some eye movements. This game in particular I love for patients that have convergence insufficiency. So a lot of people with dyslexia or difficulty with their depth perception or reading near, they have some insufficiency in convergence, which is bringing the eyes close together. And this game just seems to really drive that pathway, so that's a fun game to use. So some other neurological rehab exercises. We got active with the video game, so here's another video game called Barnyard Pickup where they have these silly cows and you're rolling a ball around trying to pick them up just to get activation of that H in space, just to get some eye movement activation along with the acoustic frequencies and the color therapy. And because we're in Atlanta, Georgia, I had a pair of roller hockey blades at my house because I used to be a big roller hockey player, and I'd have him do what are called translational exercises to activate his otoliths. So forward, back, some side to side stuff with his head turned in different directions. He hadn't been on skates since his concussion, so he loved this one. We also, of course, down here had some intermittent fasting to help drive ketosis. In a concussion, that shows to be, in the literature, really good to kind of clean up the system a little bit. So what we do is 16-hour fast 2 to 3 days a week, and you can do it overnight. So if you go to bed at like 8 o'clock at night, you wake up at 8, that's 12 hours, add another 4 on, and by noon you can eat again. So it's pretty simple to do. You just skip breakfast once or twice a week, but it's really helpful for brain. And then we had him on some Mag 3, which he really liked. So after 2 days of treatment, he was able to begin to speak, but it was really difficult. It took a lot of effort to get even just one letter out, and he would describe it, just like I mentioned earlier, as the letter getting stuck. So here I'm asking him to try to say the letter B. So he's happy. It was really cool to hear him say that, especially after doing 2 days of intensive therapy, but a lot of work to do. So continuing on with some of the neurological exercises, this is mirror writing, and I'll show you what it looks like. So I would have him write fun things. He's a big basketball fan, so he's a Houston Rockets fan. But you can see he's writing.
W.
Saying letters now.
I. L.
So great stuff going through that. Writing and drawing are great therapies, and if you can do some stuff with it, it'll just make it even better. So after 4 days, he's speaking more fluently, but it's difficulty with repetitive speech and long sentences. He had a lot more energy and less brain fog. So you can see it's almost like his eyes and his face are starting to light up a little bit, which is always a good sign that the thunderstorm's starting to clear out.
My name is Jess.
So he's trying to say my name is Jesse. Still doing really good, but again, it fluctuates. As soon as he gets tired, he'd kind of revert back a little bit, give him some rest, do some intermittent fasting, have some Mag3, eat some healthy protein, and he'd start to get better. So he was about to head home to Alaska. He's speaking much more fluently. He didn't have any ankle clonus present. Gag reflex was within normal limits. Much less brain fog, and his cerebellar pathways were awesome. We also I had another clinician that I work with, Dr. Mike Longyear. He came down and did some neuroemotional technique with Jesse because I found that, well, first of all, I wanted to see what else we could do for him because I wasn't quite sure. I wanted to make more progress faster. But second of all, I feel like there's always some sort of emotional component that needs to be addressed, and NET was awesome for this young guy. But here he is about to go home after a week.
My name is Jesse.
So he's happy. He sounds like awesome. I still get goosebumps when I hear this because it was cool. He worked really hard, but we still had a lot of work to do. So I sent him home with some of our neurological exercises. He continued to do them, and thanks to FaceTime, we were able to check in once, twice a week, and we still communicate it to this day. He's probably getting sick of me, but I always just like to check in. But here he is back home, and this is pretty much standard for him now.
Hey, Dr. Ryan. Woke up feeling pretty good today. Just going to keep getting better, and just wanted to say thanks.
So that's, I believe, it. But, I presented this case. I know it's a post-concussion patient. It's not a lot of pain. He did have shoulder pain, neck pain. Those happen with trauma. But this was neurogenic inflammation and neurogenic neuroinflammation. So there's a lot of good things that we can do. It just goes to show you, the power of the human body, and if we give it the right resources and the right tools to get back in line, it can get there. So I believe that's it, and just thank you so much, and I hope you guys are enjoying the class. I know it's a little bit different than what was expected, but I think this is a little bit more fun and a little bit more applicable clinically. So have a great day.